Now that we have an understanding of the anatomical background, our next objective is to understand how the lungs are ventilated, or how does pulmonary ventilation or breathing occur. Breathing consists of repetitive cycles of inspiration and expiration. One respiratory cycle is a complete inspiration and expiration. During rest, our breathing is effortless and automatic. It's called quiet respiration. However, during exercise, we might have deep and rapid breathing or forced respiration. The flow of air in and out of our lungs depends on a pressure difference between the air pressure within the lungs and outside the body. Breathing muscles will change the lung volumes and create differences in pressure relative to the atmosphere, and thus draw air in or release air from our lungs. So first, let's explore the respiratory muscles. The diaphragm is the prime mover of respiration. It's the big respiratory muscle. When it contracts, the diaphragm enlarges the thoracic cavity by pulling down into the abdominal cavity. It pulls air into the lungs. As the diaphragm relaxes, it bulges upward again, compresses the lungs, and expels air. It accounts for about 2/3 of the airflow all on its own. We also will have some other accessory muscles, internal and external intercostal muscles. Those are the muscles between each of the ribs. And then the scalenes. So the internal and external intercostal muscles are synergists to the diaphragm. They stiffen the thoracic cage during respiration and prevent it from caving inward when the diaphragm descends. They contribute to enlargement and contraction of the thoracic cage. They add about 1/3 of the air to ventilated lungs. And then the third muscle involved is the scalenes, and the scalenes are a synergist to the diaphragm. During quiet breathing, the scalene muscles of the neck hold stationary ribs 1 and 2, while the external intercostal muscles pull the other ribs upwards. Since most ribs are anchored at both ends by their attachment to the vertebral column at the proximal end and their attachment to the costal cartilages at the sternum, they sort of swing upwards like handles on a bucket and thrust the sternum forward. This acts to increase both the transverse or left to right volume as well as the anterior-posterior diameters of the chest cavity. So there are many other smaller accessory respiratory muscles. They mainly act in forced respiration. During forced inspiration, we see the erector spinae, the sternocleidomastoid, pectoralis major, pectoralis minor, and the serratus muscles. The action of all these muscles will greatly increase the thoracic volume so we can take in more air during exercise. During normal or quiet expiration, we see the process is predominantly passive. It saves energy. This is achieved by the elasticity of the lungs in the thoracic cage. Basically, all the muscles relax. The structures recoil to their original shape, thus create a smaller space in the thoracic cavity, and air is pushed out of the lungs. During forced expiration, we'll see the accessory muscles like the rectus abdominis, the internal intercostals, and other lumbar and abdominal muscles, as well as pelvic muscles. This greatly increases the abdominal pressure, pushes the viscera up against the diaphragm, and increases thoracic pressure, thus forcing air out. The Valsalva maneuver also involves some of our accessory muscles for respiration. Valsalva maneuver is used during childbirth or urination or defecation or vomiting, and it consists of having a deep breath so the lungs are full of air, and it's held in by closing the glottis. Then when we contract the abdominal muscles, we raise the abdominal pressure, which pushes on the particular organ of question, whether it's the uterus or the bowel or the bladder, and pushes the contents out. So we will address the neural control of breathing very quickly here, not going into too much detail. But as you know, it's under involuntary control. However, we can exert voluntary control over it. Breathing is a brainstem function. And when we exert control over the breath, it comes from a top down where the cortex is modulating the brainstem. The primary nerves are going to be the phrenic nerve and the intercostal nerves. Now, in the brainstem, there are several different respiratory centers. I don't want you to get into the details of understanding that, just understanding that the respiratory centers are in the medulla oblongata and the pons. Now, there are central and peripheral inputs to the respiratory centers. That is, there are sensors that we learned about when we looked at the circulatory system that will trigger a respiratory response. First of all, hyperventilation, which can be triggered by anxiety, because rapid breath, it expels a lot of CO2 from the body. It expels it faster than it's being produced by the tissues. As the blood CO2 levels drop, the pH rises. This causes the cerebral arteries to constrict and reduces cerebral perfusion. This causes dizziness and could cause fainting. If we rebreathe the expired CO2 from a paper bag, that can take the hyperventilation triggered by anxiety away. We also are aware of some central chemoreceptors. The brainstem has neurons that respond to changes in pH of the cerebral spinal fluid. The pH in the cerebral spinal fluid will reflect the CO2 levels in the blood. So this happens right there by the respiratory center. When the respiratory center maintains the stable pH, it also ensures a stable CO2 level in the blood. We know of peripheral chemoreceptors located in the carotid and aortic bodies of the large arteries above the heart. They respond to O2 levels, CO2 levels, and pH in the blood. There are also stretch receptors that are found in the smooth muscles of the bronchi and bronchioles. They respond to inflation of the lungs. The Herring-Brewer reflex is triggered by excessive inflation. It's a protective reflex that inhibits the inspiratory neurons to stop inspiration when the lungs are stretched too far. There are also nerve endings amid the epithelial cells of the airway. They're irritant receptors. They respond to smoke, dust, pollen, chemicals, fumes, cold air, and excess mucus. And they trigger protective reflexes such as bronchoconstriction, shallower breathing, breath holding, or coughing. The voluntary control we have over breathing originates in the motor cortex of the frontal lobe. It sends impulses down the corticospinal tracts to the respiratory neurons and bypasses the brainstem. As you know, we can have a fairly wide degree of control over our own breathing. However, there are limits. There's a breaking point, and it's mostly triggered by CO2 levels. When CO2 levels get too high, the autonomic controls override one's will. You all know that a child can't hold their breath until they suffocate. This is that breaking point. So now that we understand the neuromuscular aspects of breathing, let's explore how expansion and contraction of the thoracic cage produces airflow into and out of the lungs. Respiratory airflow is governed by the same principles of flow, pressure, and resistance as we saw in blood flow. The flow of a fluid is directly proportional to the pressure difference between 2 points, and the flow of a fluid is inversely proportional to the resistance. So atmospheric pressure is what drives respiration. That's the weight of the air above us. At sea level, it's about 760 millimeters of mercury. That's 1 atmosphere. It's lower at higher elevations. So up here in the mountains, we're probably about 840 millimeters of mercury. At a constant temperature, the pressure of any given quantity of gas is inversely proportional to its volume. This is Boyle's law. So if the lungs contain a quantity of gas and the lung volume increases, the internal pressure will fall. If the pressure falls below atmospheric pressure, then air will move into the lungs. However, when the lung volume decreases, the intrapulmonary pressure rises. If the pressure rises above atmospheric pressure, then the air will move out of the lungs. So it's all about pressure difference between the inside and the outside of the lungs. When we inspire, the two pleural layers, and they have a cohesive attraction to each other, and their connection to the lungs and the lining of the rib cage bring about inspiration. So when we consider inspiration, it's about the two pleural layers. They're cohesively attracted to each other by the fluid that's between the pleural layers. And one is connected to the lungs, and the other is connected to the rib cage. When the ribs swing upwards and outwards during inspiration, the parietal pleura follows them. The visceral pleura, the one on the lungs, clings to it by the cohesion of water, and thus it follows the parietal pleura. This stretches the alveoli within the lungs. The entire lung expands along with the thoracic cage. As it increases in volume, its internal pressure drops and air flows in. This is what we see here during inspiration. So this interpleural pressure is the slight vacuum that exists between the two pleural layers. And it's about -4 millimeters of mercury. And it drops to about -6 during inspiration as the parietal pleura pulls away. Some of this pressure change transfers to the interior of the lungs. The interpulmonary pressure in the alveoli will drop to -3 millimeters of mercury. The pressure gradient from 760 millimeters of mercury to 757 millimeters of mercury in the alveoli allows air to flow into the lungs. So it's a relatively small pressure change, but it's enough to draw air in. Another force that expands the lungs is related to Charles's law. Charles's law states that the given quantity of gas is directly proportional to its absolute temperature. So on a cool day, let's say 60 degrees Fahrenheit, air will increase its temperature by 39 degrees Fahrenheit during inspiration. Because by the time the air reaches the alveoli, it needs to be warmed to about 99 degrees Fahrenheit. So the inhaled volume, let's say, was originally 500 milliliters, will expand to 536 milliliters. This thermal expansion is going to contribute also to the inflation of the lungs. During quiet breathing, the dimensions of the thoracic cage increase only a few milliliters in each direction. This may seem small, however, it's enough to increase the total volume by 500 milliliters. Thus, 500 milliliters of air flows into the respiratory tract. During expiration, in relaxed breathing, it's a very passive process. It's achieved mainly by elastic recoil of the thoracic cage. This recoil compresses the lungs and the volume of the thoracic cavity decreases. It raises the interpulmonary pressure about 3 millimeters of mercury, and thus air flows down the pressure gradient and out of the lungs. However, during forced breathing, the accessory muscles will raise the interpulmonary pressure as high as 30 millimeters of mercury. Massive amounts of air are going to move out of the lungs in this case. Now, as we've introduced, the pleural membranes have a fluid between them that allows the organs to slide over each other. This fluid creates a cohesive force that allows the lungs to expand as the thoracic cavity changes shape. In the condition of pneumothorax, we'll find air in that space. This happens when the thoracic wall is punctured. And inspiration, rather than sucking air in through the mouth into the lungs, can suck air in through the wound into the pleural cavity. So this potential space becomes an actual air-filled cavity. And thus, we lose volume in the lungs. There's a loss of negative interpleural pressure, and that allows the lungs to collapse. When a lung collapses, It's called atelectasis. Not only can it result from pneumothorax, but it could also result from an airway obstruction. So now is a great time for some diagramming. Pull out a piece of paper and do what you can to diagram what happens with the pressure changes in the thoracic cavity to cause inspiration and expiration. Include the ribs, the diaphragm, the pressures involved, and the volume of the lungs. So just as with the circulatory system, there's going to be some resistance. Pressure was one component, resistance is the other. The greater the resistance, the slower the flow. There are three factors that influence airway resistance: the diameter of the bronchioles, the pulmonary compliance, and the surface tension of the alveoli and distal bronchioles. Let's look at the diameter of the bronchioles. An increase in the diameter of the bronchus or bronchiole is called bronchodilation. It's stimulated by sympathetic stimulation and epinephrine. It acts to increase airflow. Conversely, there's bronchial constriction. This decreases the diameter of the bronchus or bronchiole. This is under control of the parasympathetic nerves. Can also be set by cold air, chemical irritant, and histamine. Suffocation from extreme bronchial constriction brought about by anaphylactic shock and asthma can cause death. The second factor influencing resistance is pulmonary compliance. That is the ease at which lungs can expand, and is measured by the change that we see in the lung volume relative to a given pressure change. Compliance will be reduced in degenerative lung disease, in which the lungs are stiffened by scar tissue. And training can actually increase the pulmonary compliance. In yoga, there's a lot of breath work. That's about increasing the pulmonary compliance so we can get much greater volume for each given pressure change. The third component is the surface tension of the alveoli and the distal bronchioles. The alveoli are relatively dry, but they do have this thin film of water over the epithelium. This film is necessary for gas exchange, but creates a potential problem for the pulmonary ventilation. Because water molecules are attracted to each other, this could cause the lung to collapse. That's why there's surfactant. Surfactant reduces the surface tension of water and allows the lungs to stay inflated, even when they're being emptied. The importance of surfactant is very apparent when we see premature infants. Surfactant is secreted just before birth when the lungs are about to become inflated by their own means. In premature babies, they haven't had enough time to secrete the surfactant into their lungs. This can result in IRDS, or infant respiratory distress syndrome. It's often treated purely by administering artificial surfactants to allow the baby's lungs to open up. So only the air that enters the alveoli is actually available for gas exchange. Not all the inhaled air actually gets there because there's all of this dead space in the lungs. About 150 milliliters will fill the whole conducting division of the airway and not even make it to the respiratory division. So anatomical dead space is a term for the conducting division of the airway where there's no gas exchange. It can be altered somewhat by sympathetic and parasympathetic stimulation, changing the size of the tubes. In pulmonary diseases, some alveoli may be unable to exchange gases because they lack blood flow or the respiratory membrane has been thickened by edema or fibrosis, and so that would also contribute to dead space. So physiological dead space is the sum of the anatomic dead space as well as any pathological alveolar dead space, such as we might see from disease. Let's say a person inhales 500 milliliters of air. 150 milliliters of that stays in the anatomical dead space. Then only 350 actually reaches the alveoli. This is where we come up with the term alveolar ventilation rate. This is the volume of air that actually ventilates the alveoli. It's that 350 milliliters times the respiratory rate, which is usually about 12 breaths per minute at rest. So that would lead us to 4,200 milliliters per minute for the alveolar ventilation rate. Of all the measurements that we'll consider, this is the one that's most directly relevant to the body's ability to get oxygen to the tissues and dispose of carbon dioxide. In addition, the alveoli never completely empty during expiration. There's always some leftover air. This leftover air is called residual volume. It's typically about 1,300 milliliters, and it can't be exhaled even with the maximum effort. So as you can see, it's often important to measure a person's pulmonary ventilation in order to assess the severity of respiratory disease or monitor patients' improvement. Measurements are made by having the subject breathe into a device called a spirometer. This device recaptures expired breath and records variables such as rate, depth of breathing, the speed of expiration, and the rate of oxygen consumption. These are some of the common volumes we could measure. The tidal volume, that's the volume of air inhaled and exhaled in one cycle during quiet breathing. That's an average of 500 milliliters per breath. The reserve volumes are how much in excess of tidal volume we could either inhale with a maximum effort or exhale with a maximum effort. Our inspiratory reserve volume could be as high as 3,000 milliliters and expiratory 1,200 milliliters. Residual volume, again, is the air remaining in the lungs after maximum expiration. This figure will help us understand these different lung volumes and also aid us in understanding some of the lab we'll do this week. Here's our tidal volume, just the regular breath. If we expire to the maximum amount, we'll have the expiratory reserve volume. What's left over is residual volume. If we inspire to the most that we possibly can, we'll see the inspiratory reserve volume. Now, if we add together the expiratory reserve volume, the tidal volume, and the inspiratory reserve volume, we have vital capacity. If we take from the bottom of tidal volume to as much as we can possibly inhale, we have the inspiratory capacity. And when we add all these pieces together, we find the total lung capacity. So here are some of the equations that we might run into. This just summarizes all that I've told you in the previous slide. Now, we may run into some respiratory disorders. They fall into two basic classes, restrictive disorders and obstructive disorders. Restrictive disorders are those that reduce the pulmonary compliance. They limit the amount to which the lungs can be inflated. Any disease that produces pulmonary fibrosis is a restrictive disorder. Black lung and tuberculosis are examples. Obstructive disorders are those that interfere with the airflow by narrowing or blocking the airway. They make it harder to inhale or exhale. Asthma and chronic bronchitis are examples of obstructive disorders. Emphysema combines elements of both restrictive and obstructive disorders. Emphysema would be a great topic for someone to cover at their presentation at the end of this semester. Here are a few different measurements. Our peak flow is the maximum speed of expiration. We measure that by blowing into a handheld meter. There's also minute respiratory volume. This is the amount of air that we inhale per minute. It's the tidal volume times the respiratory rate. And then maximum voluntary ventilation. This is during heavy exercise. It can be as high as 125 to 170 liters per minute in a very fit individual. Here are a few terms that you may find of interest when considering variations in respiratory rhythm. This is just extracted from a table in your textbook. Eupnea, relaxed, quiet breathing. Apnea is our temporary cessation of breathing. Dyspnea is labored or gasping or shortness of breath. Hyperpnea is increased rate and depth of breathing in response to exercise, pain, or other conditions. Hyperventilation, increased pulmonary ventilation in excess of metabolic demand. Hypoventilation is reduced pulmonary ventilation. Cosmal respiration is deep and rapid breathing. It's often induced by acidosis. Orthopnea is dyspnea that occurs when a person is lying down. Respiratory arrest is the permanent cessation of breathing, and then tachypnea is accelerated respiration of any sort. So that brings us to the end of our section on pulmonary ventilation. Be sure that you've taken some time to diagram out the process of respiration that I suggested earlier. And we'll move on now to the physiology of how gas is exchanged and transported in the blood.